Welcome to OECD Podcast, where policy meets people.
High-quality statistics are the foundation of the OECD's signature policy analysis, including policies relating to health. The pandemic underscored the importance not only of understanding health data, but making it publicly available as quickly as possible to inform urgent decision-making. While the worst part of the pandemic is behind us, health statistics remain as important as ever. In fact, a brief look at the analytics for the OECD's data warehouse shows that two of the most consulted databases relate to health expenditure and financing and to mortality. I'm Ashley Ward, and today we'll be delving into the world of health statistics. Joining me are two experts from the Health Division of the OECD's Directorate for Employment, Labour and Social Affairs, here to shed light on the significance of health statistics and their impact on policy decisions. David Morgan is Head of Health Accounts and a Senior Policy Analyst, and Gabriel de Paolantonio is a statistician within the Health Statistics and Country Monitoring Unit. Welcome both to the podcast.
Thank you very much. Happy to be here.
Thanks for having us, Ashley.
So, as I noted at the top, the two indicators at the top of analytics are health expenditure and financing and weekly mortality data. But why do you think so many people are consulting health statistics in general? And in other words, why are they so important even as we come out of the pandemic?
First of all, I think we're pleased to hear that health statistics and these particular data sets are one of the most consulted. I think there's a general interest in health and health statistics. And in addition to just these two data sets, I mean, OECD Health Statistics is a huge, wide database covering lots of different areas of health statistics, from resources, number of doctors, number of nurses, etc., to risk factors on how much are people in different countries smoking or drinking. Now, this is a very wide-ranging in the data set that we have. And the OECD generally has been working in this area for more than 20 years. So it's the go-to place, really, to get a wide range of health statistics across OECD and increasingly across non-OECD countries as well. To come to the health expenditure and financing in particular as one of the most consulted databases, well, OECD is first and foremost an economic organisation and has really been at the forefront of developing a robust framework to measure and track health spending and financing across countries for many years. So the framework was developed in the OECD, and now it's become a global standard, but OECD remains really a dominant player in this area. So those looking for information on what each country spends on healthcare really see OECD as the natural first place to go to get this information.
And Gabriel, what about mortality?
On excess mortality and on mortality in general, we attended the needs from countries, especially at the beginning of the pandemic, as well as researchers and public in general, to measure the impact of COVID-19 was having. At the time where countries had different capacities on testing, one of the ways in which we could measure mortality on a more comparable way was to analyze all-cause mortality. And thanks to that, then we started developing indicators both on excess mortality as well as on the percentage change of all-cause mortality between the current year, so at the time 2020, 21, up until 2023 at the moment, compared to a baseline of 2015 to 2019, to take into account which was the impact of the pandemic compared to a baseline of mortality we were having in OECD countries. And more recently, after the pandemic has started to fade away, we are addressing areas such as the impact of other respiratory viruses, heat wave, natural disasters, and other external episodes on all-cause mortality.
Perhaps I could just add to that in that, as most of our statistics in database tend to be annual statistics, one of the innovative things about the mortality statistics is that we were updating them really on a weekly basis. So the demand for very timely and frequent data was being met, particularly through the pandemic, but we've continued to do that to track mortality at a very timely level.
Yeah, so it's clear to me that the OECD Health Accounts is sort of a benchmark internationally from what you've said, 20 years of experience, and then the mortality data innovative coming on a weekly basis, responding to urgent needs. You recently hosted the Health Ministerial meeting where you brought together ministers from OECD countries and beyond. What were your main takeaways on the measurement side? There were a lot of policy issues discussed, but measurement sometimes falls by the wayside. What do you feel like OECD members value most when it comes to the data?
Coming out of the pandemic, and this was really timely for health ministers to come together and face now with a lot of other issues around, the impact of inflation and of course, global threats from other areas such as climate and regional wars as well. I think looking forward and monitoring what's happening in the health field, health ministers really welcome the overall quality, breadth and comparability of the international statistics that OECD can give on this so that they can track the trends, coming back to health spending, but in mortality as well. So I think one of the main takeaways coming out of the ministerial was in being able to build more resilient health systems and populations to counter those future crises, to track the further spending in areas, particularly around prevention and public health. And so the kind of detailed data, the robustness of the data and comparability across countries can really make it clear whether progress is being made against these targets and provides a way of really benchmarking, as you say, against other countries.
Nice. And then how about you, Gabriel?
So going on mortality and more in general as well on other health statistics, there was a mandate from the ministerial for the OECD to keep abreast of collecting more recent data and to have it disaggregated by sex. The mortality database is one that was already taken into account these aspects. As David was mentioning, it is updated weekly, and most of the data we have can go back up only a couple of months. So, for example, right now, we're already consolidating 2023 data. So that, plus the fact that we have been able to present this data disaggregated by sex when countries had the availability of these indicators so that we could extract, represents the ability of the OECD to keep abreast on these kind of issues and to follow the mandate that was given to us during the ministerial meeting.
Nice. I think what stuck out to me there a little bit was the mortality side. So COVID-19 was clearly a catalyst to create more timely indicators, both on the economic side, creating more timely indicators of GDP and of inflation, for example, but then also on the health side. And then the important thing here is mainstreaming, not just forgetting the lessons we've learned, but taking these forwards. But focusing on you, David, for a second, let's unpack this health expenditure and financing database. You mentioned a couple of indicators earlier, but if I had to pin you down to, let's say, 2 key indicators that an uninitiated user might focus on, what would they be and why?
Before I get to the actual indicators, I think it's important to know a little bit about the data that we do publish on health expenditure and financing, because it's important when you are comparing between countries that you want to be comparing the like with like. As I mentioned at the beginning, the OECD has developed this framework called the System of Health Accounts, which really gives an accounting framework for countries to follow. And what the main part of that, first of all, is to really define what health is. Health can mean very different things across different countries. We really set the boundaries of what countries could report. And then within that, there's a breakdown really focusing on, what kind of services are provided. This could be in terms of inpatient care or how much is spent on pharmaceuticals. Then there's the other side of who's providing these services, whether it be hospitals or GPs or pharmacies. And then importantly, also is then who's paying for it. It could be governments or it could be coming out the pockets of the patients themselves. Having said that, then, what are the main indicators that people come to the database to find? And I suppose whether you're a journalist or public, you're interested overall in how much is being spent out of the economy. So as a share of GDP would be probably our number one indicator that's sought after most.
Just quickly on the spending as a percentage of GDP point, how does that compare across OECD countries?
Well, in general, if you look at the average, then OECD countries are spending close to 9% of GDP on health and healthcare. As you can imagine, this varies quite a lot. We have right at the top, the US is by far the biggest spender at around 17%. But a lot of the Western European countries and Scandinavia are typically spending 10, 11% of GDP. At the bottom, we will have Latin American countries and Turkey, more around the level of 5%. Second to that would be another indicator of looking at how much in monetary terms is being spent by each member of the population and how that's split down between the various services. Going beyond those main 2 indicators, then there's an interest in, how much is being spent out of pocket. What is the share that comes down to the individual paying for their healthcare?
Okay, so maybe looking at these 2 indicators, what did we see during the pandemic? What have we seen since? Have countries sort of bolstered their health systems? Are they spending more on health than ever? What does this picture look like?
Of course, the pandemic was a huge shock. It wasn't just a public health crisis, but also an economic crisis. I mean, we probably all know that the health spending over the last few decades has been generally increasing in most countries as societies tend to age and the demands grow for more and more healthcare and more innovative treatments and pharmaceuticals come to the market. But then when we come to the pandemic, there was a sudden need for governments really to step in with some emergency resources. So OECD countries saw unprecedented increases, particularly in public spending on health, with first an urgent need to spend or to reinforce systems to test and trace infections across populations, and then really moving on to the development of vaccines and vaccine programs for mass population-wide campaigns. So this resulted in unprecedented increases in health spending of more than 8% in real terms by 2021, followed obviously as we moved out of the acute phase of the pandemic with a drop in 2022. But levels are still higher than they were pre-pandemic.
So part of the unique selling point of the OECD is that we create sort of cross-country comparability and we allow countries to benchmark against each other, right? So what work happens behind the scenes to make that happen? What other organizations do you work with? What does this look like? Can you give us a peek behind the curtain?
Well, coming specifically to the health expenditure and financing data, I mean, we work very closely, and we have done for many years, together with the World Health Organization and Eurostat from the European Commission, to really together ensure the quality and the comparability of the data that is eventually published. And one of the key points of developing this trilateral relationship is to avoid the situation where, different data is found on the database of Eurostat or the WHO. So we're all talking about the same thing. There's a very rigorous process that we go through with the countries and the international organizations to ensure that the data is comparable and robust. I suppose the other point about the data as well is that we want to make the data as timely and as punctual as possible. So it means that we work hard to ensure that really the maximum amount of time between a country submitting and the time that we publish is down to a minimum. Typically, we publish the main part of our database around the end of June, beginning of July, which means there's really only a 6-month period after the last reference year.
And is it similar for you, Gabriel? What's the behind the curtain for you?
So, in fact, for the recent mortality trends database, we have an inter-directorate effort. In EADS, we collaborate as well with WISE, who are basically taking most of the extraction process. And then, of course, this brings some technical issues, for example, that needs to be controlled every time we are updating the data, which can be, for example, making sure that the URL we are using to extract the data is updated, because sometimes this change, either if it comes from a national data source or from a regional data source from which we take the all-cause mortality figures. And that brings as well a more analytical aspect on the behind-the-scenes work that we have on the recent mortality trends database, which is the ongoing debate that exists on which baseline to use. For example, right now, when we talked about the percentage change of all-cause mortality, we take into account the year we want to study and then the baseline of 2015 to 2019. So generally, on all-cause mortality literature and methodology, you use the previous 5 years to the ones you currently have. But because of the exceptionality of the COVID-19 as a period of a very high mortality, unfortunately, of course, then we are in the position, or there's the necessity to keep using the 2015-2019 data as a baseline. And then, of course, checking what can be behind, for example, when we observe some high mortality in certain countries. So it could be, for example, for other respiratory viruses, for heat waves, as well as natural disasters and so on. So that is why this is a very important tool that we have and that we are trying to, let's say, decouple in some sense from the COVID-19 pandemic to keep it current and to keep it valid for policy analysis at the OECD.
Data on mortality came to the fore during the pandemic, obviously, for all the wrong reasons, and that changed the baseline that you ended up using. So you now use 2015 to 2019, as you said. But how else, since the pandemic, has your job changed? What, for you, are the important changes that you see in the measurement effort of the OECD in terms of mortality data?
So mortality, as David was saying before, we managed to develop and constantly update and publish a weekly data set with data that goes back only a couple of months in some cases. That's a first for the OECD Health Statistics, having data that is so recent As well, we have managed to expand the coverage of countries. So at the beginning, it was not that easy or straightforward to get all-cause mortality data from all countries. But so far, we have managed to increase this to 32 member countries with weekly all-cause mortality figures, which are available in the database. So users can access it in OECD.stat or in the new data portal. And it's figures that are, of course, featured in some of our flagship publications. So, for example, we have Health at a Glance 2023 that was released back in November, and on which we have a two-pager dedicated completely to the recent mortality trends data. Then we also have managed to increase the robustness of the indicator, thanks, for example, to HS standardization to account for demographic changes.
Perhaps I could just add to that, because obviously these are very high profile and sensitive statistics as well. So we have to be very clear about the robustness of the figures. And on the other point about, yes, this was innovative in terms of having weekly statistics and more high frequency statistics. I think this has opened the door a little bit to a growing demand to have more frequent statistics. So we're starting to look at what other areas we can get information on in terms of hospitalizations and visits to emergency care departments, etc. And this kind of information is not just important to put out there in the public domain, but it's key to our research as well, as we look at the impact of heat waves on mortality or the number of people ending up in hospital.
Completely right, David. On the robustness of the methodology, we're always pushing at the OECD for not just more timely and more granular data, but also more trustworthy data. So having sort of transparency of those robust methodologies is vital. But maybe we can set aside those two databases that are sort of in the limelight, that are so regularly downloaded and consulted on the OECD's data platforms, and think about what other health indicators people might be paying attention to, widen our perspective. Can you tell us a little bit about some key indicators that might be informing the OECD's health policy analysis recently?
The health database, health statistics itself is much broader than the areas we've just focused on in terms of expenditure and mortality. It's one of the, if not the biggest database in the whole of the OECD statistics. And it covers very many different areas in terms of what resources are going into the health system, the outcomes, life expectancy, mortality, the risk factors of the population as well. And there's a growing epidemic, if you like, of obesity, which is hitting many OECD countries. So all these are important areas. One of the most politically challenging areas for health policy is in the area of workforce, the lack of sufficient doctors and nurses to meet the growing demand. So the health statistics collect a broad range of information across the number of doctors, the number of nurses, but going down into more detail as well about, breaking this down by age and gender to really be able to model and see what will be the impact of health professionals retiring in the years to come. Apart from that, there are important areas of healthcare quality that we monitor as well. Perhaps Gabriel wants to mention a bit more of that, as a particular area that he's worked in.
Yes, so in fact on healthcare quality and outcomes, which we published back in June, and then we observed as well indicators that were useful during the pandemic and that are also useful during less exceptional times. So for example, we see areas of avoidable admissions, which is also something that's very high on the agenda of most of member countries that want to know on ways of how to lower this health issue, especially in a time where we have such a big backlog of unmet healthcare needs due to the pandemic as well. And as David was mentioning, due to the ever-growing lack, unfortunately, of doctors and nurses to cover all the demand that the healthcare sector is having in most member countries. Then, of course, everything that has to go with pandemic preparedness, that is something on which we are also paying special attention on the area of health statistics to allow countries to make evidence-based decisions, thanks to the indicators that we either collect or for which we try to improve the comparability across the OECD.
We've discussed so far what we're already doing, really valuable work. But what's coming up? What exciting projects are in the pipeline to try and improve the timeliness, the granularity, the country coverage, or present new indicators for our members?
Right now, we're also working a lot on disaggregating data by sex, as well as by age, which is part of the mandate of the ministerial. And then we're also trying to have more timely data. Because right now, or before the pandemic, what we observed generally is that data was corresponding to T-2, or as we call it, T-2 data. So, for example, in 2024, we are able to collect indicators going mostly up of 2022. So right now, we're trying to reduce that gap and, for example, getting indicators on T-1. So indicators from the previous year, or even more recent, as we are doing in the recent mortality database. Those, for me, will be the two main areas that will go horizontally across most of the health statistics databases.
Just to add to that, in terms of granularity, one of the big issues in health is the growing disparities between different income groups and different subgroups of the population. So Gabriel mentioned about getting more and more disaggregated data by sex or gender, but we also want to try to link this more to socioeconomic status. So we can look at the impact of levels of income in how different income levels can access services, and ultimately what are the outcomes in terms of life expectancy and mortality. So that's a clear area where we want to improve our information. And some of the other particular areas that we're looking to as well, which I mentioned as coming out of the ministerial, there's a need to develop more about what is the impact of climate change on health and environmental indicators around there. And I suppose one of the main projects that has been going on for, really 7 years since the previous ministerial was to develop indicators of patient experiences from the health system. So measuring what matters to patients, what is the outcome of the health care that they've received. And this has been led to the development of a huge survey, the biggest survey of patients with chronic diseases over the last year. And the results of that are starting to come in now. So this will be a big area of new data that is not available anywhere else to really measure the impact on patients' lives themselves and resulting from the care they've given. So this is an exciting area, and I imagine there'll be an additional podcast on this at some time to really explore these innovative results, which will come out from what is called the Paris survey, the patient-related information surveys.
Okay, well, we'll be paying close attention to those projects, to Paris and to the mortality database and to the health expenditure and spending database and health statistics in general as one of the key assets for the organization. David, Gabriel, thank you so much for helping us dive into them today.
Thanks very much, Ashley. It's been a pleasure.
Thanks, Ashley.
Today, we've gained some extremely valuable insights into how health data is compiled and processed here at the OECD. As with every indicator we produce, our colleagues' work on health statistics is pushing the frontier of timeliness and granularity in order to keep producing relevant data that informs policy decisions. The COVID-19 pandemic might be largely behind us, but we need to think ahead and be prepared for future events that may test our healthcare systems. Only with the best possible data to inform decision-making can we look towards the future with confidence. Again, a big thanks to our guests from the Directorate for Employment, Labour and Social Affairs for their insights. Join us next time when we'll dig into more key OECD statistics and indicators to help you make sense of today's pressing challenges. Until then, you can find us on X, formerly Twitter, or LinkedIn at OECD Statistics, or reach out to us via email at stat.contact@oecd.org. As always, stay curious and keep exploring the world of data.